So we would like to finish this IC with the concluding talk of Dr. Devesh Kumawat, uh, Assistant Professor, RP Center, AIMS. Over to you, Dr. Devesh.
Okay, thank you, Dr. Vibhuti, for the kind introduction. So I'll quickly take you to the cases here. 10-year-old male patient. This was the time when I was working at Kalavati Sharan Children Hospital, Delhi, which is affiliated with the Lady Hardinge Medical College. Patient had aplastic anemia, was awaiting bone marrow transplantation, and in the interim period was having blood transfusions. And the patient had developed diminution of vision in both the eyes for the last 3 months. Vision in right eye was finger counting, and left eye was finger counting 2 meters. Ultrasound in the right eye revealed vitreous hemorrhage along with submacular echoes suggestive of submacular bleed. And in the left eye, we had subhyaloid hemorrhage, submacular bleed, and intraretinal bleed. The photos are of the left eye. So after optimization of the hematological derangement, the patient was taken for pars plana vitrectomy in the right eye. The patient underwent PPV along with some macular injection of cocktail of RTPA and air hair, and followed by 20% SF6 for endotamponade. So here we are first removing the core vitreous, and after removal we see there are dense hemorrhages which are involving the retinal, subretinal, and the preretinal space. We have done the PVD, and now there is a thick sheet of ILM which is there, and we are peeling it off because it was very thick and adherent. And now using a 38 gauge needle we are injecting the drug. So first we have injected the tPA alone at this site, and the blab has formed. And then at a different site, now we are injecting the gas. And now as we see, the gas bubble has gone anteriorly. Now in this case, after FAX also it didn't come, at that time it didn't come posteriorly. We did FAX and then used 20% SF6 for endotamponade, and this is at 2 weeks follow-up. The vision was 3/60. Please excuse for the quality of the images because it was a 20-year-old fundus camera that was available, that was only available at that time. And this is at 6 weeks. The patient had vision of 4/60, and this is the OCT. Although we can make out the external limiting membrane continuous in that area, but hardly any ISOS junction or the ellipsoid zone is visible in that part. So the patient has 4/60 vision. Now, thereafter I shifted to RP center, and now we are grateful enough to have a compounding pharmacy there, ocular pharmacy, and the ocular pharmacy is compounding aliquates there. So Altiplace is being used, and of these two companies I have no financial interest, and aliquates are prepared in the dose of 0.2 milligram in 0.2 ml, that is 100 microgram in 0.1 ml, and then we dilute it further in the 1:10 ratio and achieve a 10 microgram in 0.1 ml of solution for injection. Now these aliquates are stored at minus 20 degree centigrades, and they are discarded at the end of 1 year. So this is a case 2, 61-year-old male patient with hypertension, diminution of vision for last 2 weeks, and there's a large area of submacular as well as pre-retinal hemorrhage which is seen, and on OCT we can see the pre-retinal as well as intraretinal and subretinal hemorrhage suggestive of a ruptured ram. FFA was also suggestive of peripheral as well as posterior ischemia, and there was delayed filling as well. So we took the patient for PPV with submacular injection. Here we used RTP as well as air again, and by the time we took the patient for the surgery, the bleed had dispersed further. So we removed the core vitreous, induced the PVD, and now we can see this mound of submacular bleed which is there, and the sclerosed vessels anterior to it. Now with the 38 gauge needle, now we are injecting the drug. After injection of the drug, we could see the mound which is there, beautiful mound, and this is the air bubble which had moved initially anteriorly, but FAX it is again moving back to the posterior pole. So at 1 month post-op, the best corrected visual acuity was 1/60 only, because there was profound macular ischemia that we saw on the fluorescein angiography, and there was a residual film of submacular bleed which was still present, but still there was a tremendous decrease from the preoperative picture. Now case 3 is a 64-year-old male with diminution of vision for past 3 weeks with the subhyaloid as well as submacular hemorrhage. There was a breakthrough hemorrhage also, and in the left eye there were drusen along with RP changes. So here we used Avastin in addition to the tPA and air injection subretinal, and this is the surgical video. We have done the core vitrectomy. We are inducing the PVD using tricot. We have done that, and now using the 38 gauge needle, we are injecting the drug. We have injected the drug separately and the air separately. Now this air, there was initial resistance to inject, so we checked it outside, and then there was sudden release, and then we injected it into the subretinal space. And this was followed by fluid air exchange and again gas tamponade. So this is at 3 weeks. The bleed has come down heavily, and then you can see there is a fibrovascular PD which is there. Although there was no, till 6 weeks time, we could not find any further reoccurrence of any intraocular or intraretinal or subretinal fluid or activity of the CNVM. So the best corrected visual acuity in this patient was 3/60 at 6 weeks. Now this is the last case, 36-year-old male patient who had road traffic accident 4 weeks back. The patient had finger counting 1 meter vision, and so here we can see there is a old hemorrhage which is there, and there is a choroidal rupture which was passing through just temporal to the foveal area, and there was a fresh submacular hemorrhage as well. Now we could have gone for just a tPA injection as well as intravitreal anti-VEGF injection in this patient, but I thought that let's try a submacular injection, thinking that it may affect the old bleed as well. It may lyse the old bleed and remove it as well. So here we injected RTPA and Avastin, and since I had an apprehension that it may blow out, there is a lot of fibrosis in the neighboring areas, so I decided not to inject air in this patient. So quickly going through the video. So after using the tricot, we have induced the PVD, remove the vitreous, and now we are injecting the drug, that is the RTPA as well as the Avastin, and a blab has formed. We have not injected air in this patient, and we can see the blab at the posterior pole at this area of the submacular hemorrhage, which is relatively fresh, and then we did the air fluid exchange. Unfortunately, the old bleed did not get lysed, but yes, the fresh bleed had got removed from, displaced from the macular center of the macular area, and there was still a CNVM scar which was present. Now the patient is under follow-up. So the key aspect that I consider for management is the size, the thickness, and the duration of the submacular hemorrhage. And yes, I have not tried the microdose injector. I have felt that yes, there is a sudden release of air that do happen, but I have noted out of 8 or 9 cases that I have done with intravitreal, with subretinal air, the blowout happened only in my first case, in the initial first case, and then I have been very careful and I injected slowly, but I have not had it in the last 7 or 8 cases that I have done using using subretinal air. But yes, a microdose injector is one thing that I'll look forward to, and for a more controlled injection. Thank you.
Yeah. Fantastic talk, Dr. Devesh. One thing just I would like to add, that when you're in an institutional practice, you have pretty trained paramedical staff with you. Usually in a private setup or in a peripheral setup, you don't often have such trained staff. So you need to have such to undertake such complicated procedures in a private setup. You need to make it as assistant free or as assistant independent as possible. So that's also one of the aspects why I advocate the use of a microdose injector. But fantastic cases and fantastic results. Thank you so much. Sir, please.
Minus 20 degrees.
For 1 year.
For 1 year. Now they made it last year. Now they are going to discard after 1 month.
20 degrees centigrade means
Minus
you are
20 degrees.
minus 20 degrees centigrade means in the kind
There are
of
separate freezers for that.
freezers means deep freeze.
Deep freeze, yes sir. And then you thaw it. They ask us to thaw it for an hour before using it.
Okay. But generally we are using the this thing RTPA from a single vial. I'm just taking it out just like Avastin, and keeping it there in the in the door, not within the in the deep fridge, but in the door at 4 degrees centigrade for maximum of 2 weeks.
So that is at
2 to
2
3
to 4
weeks.
degree, but this
2
is
to
at
4
minus
degree.
20.
Yes,
so
minus
that's why
20. Okay,
So
you can
that's
keep
why
it for.
we are able to store it at till 1 year.
Now, I was thinking maybe if you are not just a minute. If you are not reconstituting the alicot and if you are keeping it directly into the deep fridge, the whole vial, so can you keep it?
That could be done, but then that will have its. If you are going to pierce it multiple times, then the risk of infection will be there.
No, not multiple, 1 or 2 times.
So
First time I have
probably
used
it
it,
will.
second time. Then if you are like submacular hemorrhage, it will come within 1 week or within 2 weeks, maximum 1 or 2 patient will come.
Yes, sir.
So I can reuse it for
So
once
here we
more.
are preparing almost 50 to 60 allocates from a single.
Single.
50
That's
milligram
true
of
because
this thing.
most of the dose of the drug will be just get
will
us.
be discarded.
Hey, once you reconstitute, can you reuse it after 2 weeks?
Sir, it's mentioned in the brochures also
Ye-
that you
yes,
should
yes.
discard within a day. Matlab if you are
Sir,
using
8
it-
hours.
but
It says
no,
8
no,
hours.
8 hours.
8 hours.
8 hours. But I have used it, and even in the in our other forum also, I've discussed it. It is they are also using it
After
with.
reconstitution, you are using.
Yes.
but
Even
how
after
do we
2
check?
weeks.
Like we can check the action. Matlab
No, yes, it acts. It acts.
It
It
acts.
acts.
So, but
Yes,
how
yes,
do
yes.
we confirm that it has not been degraded to?
That is very difficult. You have to do the other studies also, like to.
So,
see
but
the
then
efficacy
in
of
that
drug.
case, sir, don't you
But
think that
clinically, the efficacy is not gone, even after 2 weeks.
so but okay, but sir, I will have my apprehensions towards it just because if it,
No,
if
that
it
is
clearly states that it has to be used in 8 hours,
Actually, the brochure
then-
clearly states that it has to be discarded.
It should be discarded after 8 hours. Within 24 hours, you have to reuse it. But I have used it, and even our other colleagues also in multiple, not in our center, even from Delhi or other, whether they are using this tPA.
Maybe it's just the company's.
They can
proposal.
reuse.
Sir, I
Even
think,
Dr. Atul Kumar also, he has advised. me
sir,
to
I
do.
think, I mean, off the chart in my head, sir, I think instead of aliquoting, it basically comes in a powdered form. So how about we divide the powders into multiple forms and then reconstitute it as and when required?
That needs the proper sterile environment.
Yeah, sure,
That is
yeah.
available only in RPC. But is not available in our center. or
But sir,
yours.
if we reconstitute it and then think of it,
Yes.
I mean, sir,
No,
if it,
it works. It works nicely.
so because then the retreatment option gets very expensive both monetarily and psychologically to the patient if that
No,
thing
for a
doesn't.
poor patient, for the next poor patient who cannot afford RTPA, I can reuse it within 2 weeks, not beyond 2 weeks. Even
Alright.
some people are using also after 1 month. Also.
Okay, sir.
Maybe the point you have raised that it can be stored in a deep freezer at minus 20 and then we can maybe use it
Yes,
beyond 1 month
maybe.
also.
Maybe.
From Dr. T.
Okay. Yes.
So I think with that we come to the end of this IC, and I thank all the participants, speakers, and the audience to be a part of this. And we look forward to meeting you next year. Thank you so much.